You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 22nd, 2025. Our topic today is COPD and asthma overlap. This is presented by Dr. Gary Salzman, a professor of medicine at the University of Missouri in Kansas City.
Everybody, this is Conferences Online and Allergy coming to you from Kansas City, Missouri today on August 22nd. Our first presentation today is going to be on asthma COPD overlap by Dr. Gary Salzman. Dr. Salzman is a pulmonologist at University Health. He's been working with our program for, we'll say, decades. Even back when I was in training, Dr. Salzman was kind enough to host the Allergy Fellows in the Pulmonary Clinic. So with that, I'll hand it over to Dr. Salzman, and thank you for being here.
Sure, thank you. So today we're going to talk about asthma COPD overlap. I have no disclosures. So this is not anything new. This goes back to the 60s when people talked about the Dutch hypothesis, this transition from bronchitis and asthma in young people, and then developing bronchitis, and then more bronchitis of the elderly. So this whole pathway is really nothing new. It's been talked about for a long time, this relationship between asthma and COPD. So when we talk about asthma COPD overlap, there's a couple different pathways that this can happen. So it can start with somebody with COPD that has peribronchial inflammation, fibrosis, mucus secretion, and then progress over time into an asthma COPD overlap. It can also start with asthma, with increased muscle mass, inflammation, luminal narrowing, eosinophilic inflammation, and then progress on to COPD. And so it can really start either way. So when we're talking about asthma COPD overlap, we're talking about kind of a combination of asthmas and COPD. It can be more asthma or more COPD. It can also change over the course of the disease. But there certainly are some similarities between asthma and COPD, and also some differences, certainly genetic patterns, influence of maternal smoking, and then with asthma, some allergy, IgE, eosinophilia, Th2 inflammation, and then COPD, we have more exposure to smoke and from biomass fuels. Every year I see several patients from third world countries that have COPD that have never smoked cigarettes, but what they have used is biomass fuels, wood, charcoal, to heat their homes and to cook food, and they've developed COPD. Interestingly enough, here's a picture right there. I've only seen this in women. I've never seen COPD from biomass fuels from men, which indicates in most of these countries, the women were doing all the cooking and in charge of heating the home, and they were the most exposed to the biomass fuel. So you can get COPD from other causes besides smoking, and biomass fuels is probably the most common worldwide, as people are using that to cook and to heat their homes. So when we talk about obstructive airways disease, we talk about patients with easy asthma. So this is really easy to diagnose here. We've got a young person, age 21, they're atopic, they've never smoked, they get recurrent dyspnea, they wheeze, they have reversible airflow obstruction, they have bronchial hyperresponses. And this is very easy to make this diagnosis here of asthma. In the same way, this is easy to diagnose COPD. They're an older individual, they're not atopic, they do smoke, they've got a really high PACURE history, they have chronic progressive dyspnea, no wheezing, no reversibility, no bronchial hyperresponsiveness. And so that is a pretty easy diagnosis of COPD. Now we get into a little bit more complicated, a patient with asthma COPD overlap syndrome stemming from asthma. So it started with asthma and then developed more into asthma COPD overlap. So they're middle age, they're atopic, not a current smoker. they're having chronic flares, they do wheeze, and they do have bronchial hyperresponsiveness. So that would be a patient with asthma COPD overlap that started with asthma and then added on COPD later. On the other hand, we have a patient started with COPD and then developed asthma COPD overlap. So they're similar. They are atopic, but they've smoked. They do wheeze. They do a reversible airflow obstruction, and they may or may not have bronchial hyperresponsiveness. So those are some of the pathways that we talk about. And in fact, there certainly is some genetic similarities between COPD and asthma. So implicated genes are listed there that are common in both diseases. So what kind of pathways are we talking about? So we can have a patient that started off with childhood allergic asthma, resulting in reduced lung function. And then their asthma symptoms may have resolved, and we see this a lot in men. They have asthma as a boy, and then after they go to adolescence, then they no longer have asthma. They're basically asymptomatic off inhalers, but then they start smoking in adolescence. And that leads to worsening lung function. They've already started at a lower lung function because of their childhood asthma, and then they develop COPD. And so that's one pathway for this asthma COPD overlap is history of childhood asthma that may have remitted, then smoking leading to worsening lung function, and then COPD plus asthma. The other issue is it starts with COPD. They're a lifelong smoker, but then they have late onset features of eosinophilic inflammation and airway reversibility. And so the asthma is added on later. And I've seen people that have start having asthma symptoms as late as in their 80s. So asthma isn't, always a person onset at childhood or young adults. And then the third pathway is airway remodeling from long-standing asthma, non-smokers, but have never used anti-inflammatory therapy. And as we know that bronchodilators like albuterol will relieve symptoms, but it won't do anything to take care of inflammation. And so these patients get airway remodeling or permanent damage to their airways. And that's why the GINA guidelines talk about now there's really no patients with asthma that it's okay just to use PRN beta agonists. All patients with asthma need to have inhaled corticosteroid and a long-acting beta agonist, and it can be started as needed, but beta agonist alone, albuterol alone, is not an option, and this is the reason, because without any kind of anti-inflammatory therapy, you're going to have permanent damage to the airway and develop fixed airflow obstruction, and then relatively resistant to treatment of this asthma COPD overlap. So this is kind of the theory behind the recommendations from the GINA guidelines is albuterol alone, even on a PRN basis on an intermittent asthma, is not appropriate. All those patients should be treated with a inhaled corticosteroid in addition to a beta agonist. So ACO is heterogeneous. You can have eosinophilic COPD versus smoking asthmatics. So you may have more characteristics of COPD or more of asthma. And therapy is directed to the predominant phenotype. But for the most part, as you can see, we treat both diseases similarly. It must include an anti-inflammatory therapy, and bronchodilators alone are not effective. This is important because in COPD alone, we do use bronchodilators alone. In patients that don't have asthma COPD overlap, it's recommended to start with bronchodilators, long-acting beta agonist, long-acting muscarinics, and then add on inhaled corticosteroids later. But in someone with asthma COPD overlap, that's really not an option. All these patients should be on anti-inflammatory therapy because to not do that in someone that has a component of asthma is not appropriate and can lead to even death. So we have data in asthmatics. If you just use bronchodilators alone, you increase the risk of dying from the asthma. So what about airway remodeling? This is kind of a picture of airway remodeling. We got a nice healthy airway here, and then the patient has an exacerbation. They get inflammation. Now, if they just treat that with a bronchodilator, just with albuterol, their symptoms will improve. and then go back to doing what they're doing. But over years and years of doing that and untreated inflammation, that will lead to this distorted airway. This untreated inflammation causes this airway remodeling, causing fixed airflow obstruction with not responsive to bronchodilators. And then this is really more COPD. So this is one of the pathways for asthma COPD overlap, is untreated inflammation in asthma developing in later middle age, like in the 40s or 50s, then fixed airflow obstruction, where all of a sudden now the albuterol is not working. And in fact, even inhaled corticosteroids aren't going to work very well, or antimuscarinics, because now you've got fixed airflow obstruction. And COPD will have chronic persistent symptoms, and you can manage to improve symptoms but not resolve them, and you can prevent exacerbations. But with asthma, the goal obviously is no symptoms, have full activities and no exacerbations. But you're not going to get that when you have this airway remodeling. So again, that's important why the GINA guidelines say every asthmatic and every asthmatic with COPD overlap needs an anti-inflammatory, needs an inhaled corticosteroid. So the spectrum of COPD is kind of really broad. Includes airflow obstruction, includes chronic bronchitis, emphysema. And so as you can see in the Venn diagram, there's a lot of overlap here. And so asthma will overlap with COPD, also with airflow obstruction. All those things are in place. Here you have a subset of asthmatics that when they come to the pulmonary function lab and they're asymptomatic, they may not demonstrate airflow obstruction. They have normal PFTs. That does not rule out asthma, because asthma is episodic and you only get symptoms when there's a trigger. So you can have asthmatic patients that don't have airflow obstruction in a PFT when they're doing it in a controlled inside, no allergens or no irritants. So American Thoracic Society had a statement that said, sometimes we just can't tell the difference with somebody with asthma or somebody with COPD. And that's why we have this asthma COPD overlap, because some of these patients don't fit into either category completely and really fit into both categories. So differential diagnosis, asthma COPD. So this is kind of the easy kind of things. It would be really easy if everything in one of these things were 100%. If all asthma started early in life, if all asthma had reversible airflow obstruction and COPD only was partially reversible. But they're not 100%. But for the easy type patient, the classical asthma, it would be onset early in life, COPD later in life, asthma, immunological stimuli, family history of asthma and COPD, cigarette smoking or other exposures, asthma intermittent symptoms, COPD chronic progressive symptoms, airflow limitations largely reversible in asthma, partially reversible in COPD. Clinical features in asthma, episodic wheezes, chest tightness, dyspnea, cough, COPD, chronic cough, sputum production, progressive dyspnea. And the inflammatory mediator, generally in asthma, is eosinophils, and in COPD is neutrophils. So this would be the easy patients. But we know in asthma COPD overlap, there's a lot of overlap here, and some patients don't fit into these boxes and fit into both boxes. And so that's how we get this asthma COPD overlap. So what about asthma COPD in non-smokers? Yeah, you can be a non-smoker. Again, if you have a long history of untreated or undertreated asthma with over-reliance on short-acting beta agonists, we talked about airway remodeling, little or no use of anti-inflammatory therapy, fixed airflow obstruction, poor response to therapy. So all those would be possible in an ACO patient with a non-smoker. In smokers, we can have a COPD patient that has eosinophilia, that has eosinophilic inflammation instead of neutrophilic inflammation. We usually cut off is between 150 to 300 eosinophils total, or a COPD patient with irreversibility, or a smoking asthmatic that develops irreversible chronic airflow obstruction. So these are all the pathways in smokers. So the prevalence of asthma COPD overlap, probably 1 to 11% of the general population, has a higher prevalence in women, more common over the age of 40. associated with allergic rhinitis, anxiety, GERD, osteoporosis. Higher symptom burden, worse quality of life, more frequent and severe exacerbations compared to asthma and COPD patients alone. So this can present more severe than either asthma alone or COPD alone. So I'll give you some cases we can talk about. So here's a 45-year-old woman, non-smoking, lifelong history of asthma, only used albuterol inhaler as needed, no anti-inflammatory therapy. Albuterol is no longer effective in relieving her shortness of breath and wheezing. She's now having frequent exacerbations requiring prednisone. She's got airflow obstruction on her pulmonary function test, no improvement with albuterol on PFTs, and she's got an increased total eosinophil count. So here's a patient who's never smoked and with lifelong history of asthma that now has developed airway remodeling and fixed airflow obstruction. So she's progressed from asthma to asthma COPD overlap because of the lack of anti-inflammatory therapy. So what's our treatment here? For this patient, we'd do triple therapy, inhale corticosteroid, long-acting beta agonist, long-acting muscarinic, either in a single inhaler like Trelegy or Breztri, or in Medicaid patients, we have to use a combination of ICS/LABA and an anti-muscarinic, since Medicaid will not pay for triple therapy. Biologic therapy directed at the asthma, really there's a lot of different options there. Pulmonary rehab, like we would do in COPD, evaluation for supplemental oxygen, and then if it gets more severe, so nocturnal BiPAP or AVAP. So these are kind of some of the options for treatment for this individual, which started as asthma and then progressed to asthma COPD overlap because of lack of anti-inflammatory therapy. Here's another case, 50-year-old man, history of asthma as a child, no symptoms or treatment after age 13. So his asthma, went away after adolescence, but now he's got a chronic productive cough with wheezing, shortness of breath with exertion. He started smoking tobacco and marijuana at age 18, has a 32-pack-year history of smoking. He's got airflow obstruction, does have improvement after albuterol, but he does not have eosinophilia. So here is this patient, basically a history of asthma, but then smoked. So we started off with a lower lung function when he got to be 13. Once he started smoking, he lowered his lung function even more and then started becoming symptomatic from the cigarette smoking and the COPD. So this is another pathway to get asthma COPD, and he does not have eosinophilia. So we obviously start with ICS/LABA, Symbicort or Dulera, which have the more rapid-acting, long-acting beta agonists with symptoms before exercise. Action plan. If no improvement, we would go up to scheduled twice a day ICS/LABA with rescue ICS/LABA or albuterol budesonide, which is Airsupra. And then add a long-acting muscarinic, add nebulized albuterol ipratropium, and then for biologics, for a patient with refractory disease, Tezspire is certainly an option where you don't need to have the eosinophilia. So this 65-year-old woman, 20-year history of chronic cough, shortness of breath, wheezing, 40-pack-year history of smoking, currently smoking a pack a day, currently taking a Norolipta, which is basically a long-acting beta agonist and long-acting muscarinic combined, no inhaled corticosteroid, frequent exacerbations requiring prednisone. She's severe obstruction, which does improve with albuterol, and she has significant elevated eosinophils. So what are the options for treatment for her? So obviously we want to do smoking cessation. That's important. We want to do triple therapy here too. And then when she's in a red zone, we do prednisone, nebulized duonebs. Biologic therapy, Dupixent and Nucala actually are both approved for eosinophilic COPD, which really eosinophilic COPD is an asthma COPD overlap. Pulmonary rehab, supplemental oxygen, BiPAP. So those are all options for this patient. that it's been newly indicated, Dupixent and Nucala, for eosinophilic COPD, although I've been using these agents for a long time in these patients, basically saying they have asthma, which they do, and I'm treating their asthma, which was approved for asthma. So COPD asthma really are this subgroup that are indicated for biologic therapy. Dupixent needs an eosinophil count of 300 or greater. Nucala needs 150 or greater for these COPD patients that actually have COPD asthma overlap, or asthma COPD overlap. Now, what about smoking, and how does that affect lung function? So all of us, in this big red line up here, as we get older, our lung function goes down. So that's, even if you don't smoke, as we age, our lung function is going to go down. The yellow line here is patients that smoke regularly and are susceptible to its effects. And some people are not susceptible to cigarette smoking, and they don't develop obstruction. But those that are, you can see this yellow line. You have this progressive downhill till you go to disability, and then you go to death. So quitting smoking here, obviously, is going to slow the decline in lung function and also prevent disability. But even if the patient's already disabled and has severe obstruction, even stop smoking at this point, at age 65, will prolong the patient's life. So it's never too late to quit smoking, and it's an important part of when you're taking care of asthma COPD overlap. You need to address the smoking. So this definition of COPD is both progressive and associated with an abnormal inflammatory response, usually neutrophils. Airflow limitation is not fully reversible. And we should consider COPD in patients that have at least a 10 or 20 pack year history of smoking, chronic cough with or without sputum, shortness of breath, onset of respiratory symptoms in their 40s, and respiratory infections that persist or recur. So these are the kind of people that we should suspect have COPD. Spirometry is obviously important. There's more office-based spirometry in primary care offices, and so we're having these patients referred to us. But really, every smoker 45 years or older should get spirometry to try to identify early their obstructive lung disease so they can get treatment. Chest x-rays can be helpful. Here's a hyperinflation from emphysema. We have low flattened diaphragms, big lungs. On the lateral, the diaphragm is completely flat here, and there's a big retrosternal airspace. This is all air trapping hyperinflation from reduced expiratory flow rate, destruction of alveoli. All these things cause this hyperinflation from COPD with emphysema. On diagnosis of COPD, but obviously risk factors, smoking, age, symptoms, persistent airflow obstruction, post-bronchodilator, FEV1 is low, and FEV1 FEC is low. So prognosis, as you would imagine, good prognosis: if you're younger, you quit smoking, you have better lung function, and you have reversibility. Poor prognosis if you're older, you're hypercapnic or hypoxic, you're tachycardic, and you're dyspneic all the time. Those are kind of the prognosis differentiations. And so here's that kind of classic demonstration of the pink puffer, the emphysematous patient who's very short of breath but is not hypoxic. The shortness of breath is from the distended alveoli, which stimulate the dyspnea receptors. And so he's very, very short of breath, has a barrel chest, but really no hypoxemia. And then you have the blue bloater, a chronic bronchitic that has lots of sputum production, and this patient is hypoxic and hypercarbic, and so that's the blue bloater. Oftentimes patients with COPD are kind of a combination of the two, but occasionally you'll see the classic patient, the pink puffer with these manifestations alone, or the blue bloater with the chronic bronchitis alone. So bronchoconstriction COPD can be partially reversible in many patients with COPD. Airway hyperresponsiveness may develop after someone smokes. And it is interesting that one of the causes of positive methylcholine challenge is smoking. If a patient's going to get a methylcholine challenge test and has smoked that morning, that can induce airway reactivity, just the smoking. And chronic inflammation associated with increased amount of smooth muscle in the airways. So in COPD, airflow obstruction can be from fibrosis, loss of elastic recoil, destruction of alveolar support, and reversible airflow obstruction from inflammatory cells, generally neutrophils, smooth muscle constriction. And again, it's oftentimes difficult to differentiate COPD from asthma, and as we can see, they do overlap. So I just thought I'd give you the assessment tool for COPD. This is from the Global Obstructive Lung Disease guidelines. This is like for COPD, this is like the GINA guidelines for asthma. So for COPD, we do spirometry, we assess for airflow obstruction. So if their post-bronchodilator ratio is less than 70%, they're divided into GOLD 1, 2, 3, or 4 in terms of severity of airflow obstruction. Then we look at exacerbations. If they've had 2 or more moderate exacerbations a year, then you would add an E onto that. So if their FEV1 is 60% are predicted and they've had 2 or more outpatient exacerbations a year or 1 or more hospitalizations, then they would be GOLD 2E. If they've not had exacerbations, but they're having significant symptoms, then they would be B. And A would be minimal or no symptoms. And so if they're not having symptoms, they would be A. So this is kind of the assessment tool for COPD. So structural changes in COPD, epithelial changes, fibrosis of the small airways, destruction of the alveolar walls, vascular changes that can lead to pulmonary hypertension. So COPD involves inflammation, bronchoconstriction, and structural changes. And how do we diagnose it? Obviously, we do spirometry, the history of smoking or other exposures, and then a history of chronic bronchitis. And chronic bronchitis is a clinical diagnosis. You don't need really any X-rays or PFTs to diagnose chronic bronchitis. It's defined as cough and sputum on most days for 3 months of the year for 2 consecutive years. And that gives you the diagnosis of chronic bronchitis. Obviously, smoking cessation is important. There's been a big focus on pharmacological treatment to help with smoking cessation. My perception is that a lot of patients don't want nicotine patches or medication because they worry about side effects and the cost. Chantix obviously has a lot of side effects. So I think that the first step should always be to talk to the patient about quitting without pharmacologic therapy, see what happens, what kind of symptoms they have, and then once you identify what symptoms you're treating, then you could start pharmacological therapy after the patient has tried at least once to do cold turkey. Some patients don't want to take medication, and that's fine. They can still quit smoking. In fact, a study we did with my medical students, we asked everybody in the clinic who had successfully quit smoking for at least 2 years how they quit smoking. And 90% of the patients did not use any pharmacologic therapy. They quit cold turkey. Only 10% of the patients use pharmacologic therapy. So it is important to talk about non-pharmacologic therapy. So that would be quitting cold turkey or hypnosis or other means that don't involve medications. We do treat COPD exacerbations with antibiotics, and the indications are increased shortness of breath, increased sputum volume, and increased sputum purulence, or patients who have to be on the ventilator. We use non-invasive ventilation for patients to improve respiratory acidosis, and that results in decreased length of stay, decreased mortality, and decreased needs for intubation. So that is a treatment option. A steroid therapy for COPD exacerbations, just like in asthma, we use a short course of prednisone. Here, 30 to 40 milligrams for 5 days is effective. We don't want to use more than 14 days because of the complications, obviously. osteoporosis, cataracts, bruising, infections. So short courses of steroids without a taper. We don't taper. So what about asthma? I think it's always important when you have an asthmatic to assess what their risk of dying from their asthma is. People still die from asthma. If they're coming in and they're having an exacerbation, they're already on an oral corticosteroid or they recently withdraw, that increases their risk. If they have difficulty perceiving their airflow obstruction or its severity, if they have comorbidity with other lung diseases, so they've got heart failure, they've got sleep apnea, they've got pulmonary fibrosis or sarcoid, that increases their risk. Serious psychiatric or psychosocial problems, low socioeconomic status, urban residence, illicit drug use, all these things increase the risk of dying from asthma. And so I pay close attention to that because those patients, obviously, I want to be aggressive at treating them, closely following them, because obviously we don't want them to die from their asthma. So this is what the lung looks like in someone who died from asthma. You can see these are mucus plugs, these little yellow plugs that are occluding airways. And then the white area around the airways is all inflammation. And so basically this patient suffocated to death with mucus plugging and airway inflammation, causing them to basically asphyxiate from their asthma. And then the airways, the normal airway, you can see right here, that's the airway, and these are the alveoli. This is all normal. And someone who dies from asthma, we can see that the airway lumen is completely obliterated. The submucosa is just filled with inflammatory cells. And so basically this is what happened. You have an overwhelming inflammatory response that caused death. And again, this is why the GINA guidelines say every asthmatic patient needs to be on an anti-inflammatory agent, needs to be on an inhaled corticosteroid to prevent this inflammation. And this is also why we use prednisone when someone has an acute exacerbation, because once it starts to get this bad, inhaled corticosteroids aren't going to work. You need systemic steroids. So bronchoconstriction is certainly a big part of this. This is 10 minutes after an allergen challenge. The airway can narrow significantly. This is the same airway. And then airway mucosal edema really plays a big role in asthma exacerbations where you have this inflammatory response. Now, this is not going to go away with bronchodilators. That's why people with asthma exacerbations come to the ER. Their bronchodilators don't work anymore because what they need is prednisone. They need steroids to decrease this inflammation. And that's why they need inhaled corticosteroids to prevent this type of inflammation. But once it gets to this point, you need systemic steroids. We know inhaled corticosteroids improve the epithelial and basement membrane level. This is a patient, uncontrolled asthma without treatment. You can see submucosa is loaded with inflammatory cells. The basement membrane is disrupted. The epithelial layer is disrupted. There's no cilia. After 3 months of budesonide inhaled steroid treatment, cilia is back, the same patient. Epithelial layer is intact. Basement membrane now is intact, and very few inflammatory submucosal cells. So inhaled corticosteroids can dramatically improve the function and anatomical appearance of the airways. Again, this is why it's important. No asthmatic should go without anti-inflammatory therapy, should not go without an inhaled corticosteroid, even for intermittent asthma. So this is our asthma action plan that we use. Obviously you're familiar with this: green zone, yellow zone, red zone. And then we have danger signs. If you can't walk or talk because you're so short of breath and you're turning blue, do not pass go, do not collect $200, go directly to the hospital now. And so this is what we give all of our patients, and make sure that they have all the tools that they need. If they're in the red zone, they have prednisone to take, and we have them go ahead and fill it and have it available at home, so they don't have to go to the pharmacy. That they have a nebulizer at home, so they can do nebulized treatment to try to bring them out of the red zone back into the yellow and then green. So they have the ways to self-manage their asthma. So this is very important for asthma. We do it also for COPD, and also we do it for asthma-COPD overlap. So an action plan is important for all three of those diseases: asthma, COPD alone, and asthma COPD overlap syndrome. All of them need an action plan. So action plans guide self-management, can reduce ED visits, urgent care and hospitalizations. They should have prednisone on hand, the bottle in their house, so they can start it. They don't have to go to the drugstore. And if they're having frequent exacerbations, they have a nebulizer with albuterol ipratropium, and that will save a lot of patients from being have to go to the ER or being admitted. Adherence, as you know, is really, really important. They need education regarding their asthma COPD overlap, and the prescribed medications is essential. They have to have correct inhaler use and spacers if indicated. And then recommend patients take an inhaled corticosteroid inhaler before brushing their teeth in the morning and evening, and that can reduce thrush and also improve adherence. If they put it right next to their toothbrush, then they'll remember to do it right before they brush their teeth. And I found that that increases adherence with inhalers that contain inhaled corticosteroids. So I see a lot of patients in clinic that are referred to me that their asthma is not responding to medications, not responding to inhalers. I even see patients, their asthma is not responding to biologic therapy. And so the most common cause of that is you don't have the wrong diagnosis. You have the wrong diagnosis. The most common reason a patient is not responding to asthma medicine is that they don't have asthma. They got vocal cord dysfunction, they have heart failure, they have reflux, they have a pulmonary embolism or sarcoid or pulmonary fibrosis. So I really spend a lot of time evaluating for these other conditions and confirming the diagnosis of asthma. They may have airway remodeling, fixed airflow obstruction that doesn't respond very well to treatment. May have persistent exposure to triggers. I had a patient, a man with pretty bad cat allergy, and his asthma was bad because of the cats that his wife had. And the wife was with him in the office one day, and I said, you know, his asthma would be a lot better if you got rid of those cats. And she said, Dr. Salzman, I think I'd rather get rid of my husband than my cats. So that's always an issue, that they don't have a controller medication. They don't have an inhaled corticosteroid containing inhaler. It's not prescribed, they don't take it, or they can't pay for it, or they simply have refractory asthma. So we know that the addition of inhaled corticosteroids markedly reduces the risk of dying from asthma. Here's data from Canada, and people that were not refilling any inhaled corticosteroid had, you know, significant increased risk for dying. But when they refilled all 12 every month for 12 months, they had a very low risk of dying. Spirometry is important. This is obstruction. This is a normal. They both have a normal inspiratory loop. This is an expiratory loop, and obviously this is obstruction. This is important both at initial diagnosis and then in follow-up to see if there's improvement after you start therapy. So treatment, so eosinophilic COPD, and again we're talking about eosinophils greater than 150 or 300. We want to add an inhaled corticosteroid to bronchodilator therapy to reduce exacerbations. If we also add a long-acting muscarinic, we can reduce exacerbations, improve lung function, and then of course we can do biologic therapy for eosinophilic COPD, both Dupixent and Nucala. Smoking asthmatics, adding an antimuscarinic, tiotropium, reduces exacerbation. Azithromycin can be helpful at preventing exacerbations, even with normal eosinophil counts, and then omalizumab. Xolair also reduces exacerbations with elevated IgE. Again, this is very important. You want to avoid long-acting beta agonist monotherapy in patients with asthma COPD overlap because it's clear that this can increase the mortality in asthma or asthma COPD overlap and should be avoided. Intermittent asthma COPD overlap. So when patients have symptoms of viral infection or allergen or irritant, you know, if they have a significant increase in symptoms, then I like to use an ICS-LAVA on a daily basis for about 2 weeks with PRN, albuterol, ipratropium in their action plan. I like this better than just doing a PRN ICS-LAVA because I think that it prevents them from coming to the ER from having exacerbation, and oftentimes it can prevent them from having to use oral steroids. So most commonly, these are triggered by viral infections, but I would like to have them on an ICS-LAVA for 2 weeks on a scheduled basis. Obese patients that may have resistance to beta agonist, along with insulin resistance. Short and long-acting antimuscarinic agents are very effective in addition to inhaled corticosteroids in relieving and preventing symptoms. So oftentimes I make sure that these obese patients are on an antimuscarinic agent in addition to a long-acting beta agonist and in addition to an inhaled corticosteroid. So triple therapy is very effective in these obese patients who don't respond very well to both long and short-acting beta agonists. So goals of therapy for asthma, we want normal lung function, rare symptoms, no activity limitations, no exacerbations. Basically, we want to hit a home run with asthma patients. COPD, we're going to want to reduce exacerbations, improve symptoms. We're not going to be able to eliminate them. And then asthma COPD overlaps somewhere in between here, depending on which is more of the issue. So I just got a couple questions here. 45-year-old woman, 20-pack-year history smoking, ratio of 60%, total blood eosinophil 350. Does this patient have asthma COPD overlap? Yeah, true. 2, treatment with salmeterol, a long-acting beta agonist alone, is appropriate for patients with asthma COPD overlap. False. No, we never want to do long-acting beta agonist alone in patients with asthma COPD overlap, or asthma can increase mortality. And then a short course of oral prednisone is effective in treating exacerbations, patients with asthma COPD overlap, and that would be true. And here is some references for you for asthma COPD overlap. And